All right, so, wow, it's a lot of stuff. So we're going to do pulmonary. We'll do it in two halves. And the only slides that are tough, just like I did in the last talk, are the first three. They're the ones with the physiology stuff on them that they always ask about. So I'm going to do those first. And then it's going to get into some really, really practical stuff, actually, just bread and butter practical pulmonary medicine, which I think actually accounts for a similar amount of space on a test as does neurology. Okay, so take a deep breath. Number one, please do not get this question wrong when they ask you, well, the simple formulas, the anion gap, this simple A gradient formula, osmolar gap, you know, those sort of common ones. Don't get a question wrong just because you didn't write those out and memorize them. So that's definitely worth knowing. And you know, A gradient is something that is made more confusing when they teach it than I think it ought to be. You know what I think about A gradient as? A gradient is the report card of the lungs. That's what it is. It's a direct measure of, are the lungs working? So when people are this is why I organize it like, so when people are hypoxemic, okay, when they have low circulating oxygen, when they're hypoxemic, it's either because of the lungs or because of something else. And really what the A gradient is that measure. If the A gradient is high, it's the lungs. If the A gradient is normal, it's something else. And you know, it's just a very simple concept. So you'll see there on the left side, a normal A gradient, you happen to live in Denver. That's not your lungs' fault, right? You happen to have done an opioid overdose and you're not breathing as much. It's not the lungs' fault, it's because you're not breathing. And then when you go to the other side of the equation, when the A gradient starts to increase, basically what it means is the lung is at fault. The lung has a problem because the lung is failing to take the concentration of oxygen that it sees and translate that into the bloodstream. So the A gradient is the difference between the oxygen level that the lungs see coming in through the trachea and what they actually are able to push into the bloodstream. And that's a lung problem. Now, when they ask about these sorts of questions, and you're like, oh, God, I mean, this is something back to physiology, I want to tell you something that's reassuring, which is it's pretty much straightforward. I mean, we know the opioid overdoses, right? We know why they're hypoxemic, right? But for all the other people, the mechanism that we see for hypoxemia of a lung problem, the ER, is almost always VQ mismatch. That's why I highlighted it. So if you don't know the answer, and they say, oh, how is this person hypoxic? You just say VQ mismatch probably, whether it's pneumonia, whether it's COPD, asthma, pulmonary embolus, all the biggies. They're all VQ mismatch mechanisms, and in all of those processes, there's some problem where blood is flowing through the lungs, but some of the blood that's flowing through isn't picking up oxygen. Really, really, that's all that it is. And that's what VQ mismatch is all about. Now, rarely in the emergency department do we see these other forms of lung problem hypoxemia, but they do happen. This concept of impaired O2 diffusion happens in a few conditions in the ER. The most important one is PCP pneumonia, which we're going to deal with in this section. And so in that type of lung disease, interstitial pneumonia, interstitial processes, the problem with getting oxygen isn't actually VQ mismatch. It's not that there's blood flowing and oxygen not working. It's actually the inflammation in the alveolar membranes. The actual fibrosis that occurs interferes with oxygen's ability to move across the alveolus. So that's a different mechanism. Most people that come into the ER, all the pneumonias, COPD, it's just a VQ mismatch. So when we get to that PCP, we'll remind you of that again. The same would be true for a rapidly progressive interstitial lung disease, which maybe some of you have seen. They're not that common. But that would also be a mechanism of impaired diffusion of oxygen because of thickened, inflamed alveolar membranes. And of course, the right to left shunt, we all know about that. I mean, those are people that have a structural problem where the heart and lungs aren't connected properly, and it makes sense that they would have hypoxemia as well. So that's a tough slide, but really every conceivable question on that subject will come off of it. This is another slide where it's just a simple concept, but many questions can be generated from it. And that's the concept of central cyanosis. Now, peripheral cyanosis, they show you a kid who's got, blue fingers and blue toes and blue nose. I mean, that's could be living in Canada, does that to you, right? I mean, you're out in the cold, acrocyanosis. When we talk about cyanosis, I want to see the tongue. I want to see central cyanosis. I want to know that's what they're talking about. And the key thing here to remember is that you can only be blue, cyanotic, you can only look blue if you have enough desaturated hemoglobin to look blue. And it takes 5 grams of desaturated hemoglobin to make someone look cyanotic. And so you can imagine if you're really anemic If you've had a GI bleed and your hemoglobin is 5, you could not possibly be cyanotic. You don't have enough hemoglobin to be cyanotic. And so just remember this mantra: you cannot be both anemic and cyanotic at the same time. Now, the corollary of that, the flip side concept of that, is the blue bloater. We all know what the blue bloater is. This is a person who's been smoking, and they have more and more hemoglobin. Their body's making more and more hemoglobin to compensate for what they're doing. So what's the hemoglobin on a blue bloater? 20, 19, right? You see these very high hemoglobins. So the thing about them is that they always look blue because they've got so much hemoglobin. Think about this for a second. If they've got 20 grams of hemoglobin and their SAT reads 75%, guess what? They have just as much circulating hemoglobin as we do. They have 15 full grams of saturated hemoglobin. So that's why blue bloaters, you look at, oh my God, this guy's blue. It's okay. He's got enough oxygen circulating. He looks blue all the time because he's got all this hemoglobin. And so that's an interesting concept that we'll probably come back to a little bit. But that comes up in many different ways. You cannot be both anemic and cyanotic at the same time. And if you've got a lot of hemoglobin, it's much easier to be cyanotic. And this is a third of the tough slides, okay? There's 4 different concepts that I want to cover with you here about the pulse ox. Now, we all know that a pulse ox of 100%, excuse me, doesn't mean that much if your hemoglobin is 2, right? So don't forget that, excuse me. And the converse of that is that, excuse me, I just got to clear my throat, hang on. So the amount of oxygen they're able to deliver to their tissues is piss poor when they're anemic, right? Now, the other concept of the supplemental O2 concept is always trips people up. They tell you that the patient has, a SAT of 92, say, and they're on a non-rebreather. What does that mean? Think about that. SAT of 92, non-rebreather. It means they're frickin' dying, right? I mean, their A gradient must be so high. Just despite the massive amount of FiO2 they're getting, they can't even get their SAT up to 100. They can't even get it up to the high 90s. And so when a patient is on a non-rebreather, and they're telling you the SAT is 89 or 90, there's a good chance they're trying to tell you he's in respiratory failure. I mean, that's about as much oxygen as you can put on externally, right? And so that's the issue there. So don't be fooled by thinking patients with a SAT of 97 are fine. If they're on a lot of supplemental oxygen, they might have a massive AA gradient. Okay, next off is the 2 tox things. They're going to come up again and reinforce these concepts in tox. But what does this pulse ox say in CO poisoning, in carbon monoxide poisoning? It says 100%, right? And the thing here to not get fooled on is that when you're dealing with carbon monoxide poisoning, it doesn't matter what you do, unless you directly measure the CO level, you're going to get it wrong. The only way to detect CO poisoning is direct measurement, co-oximetry of the CO level. If you take the pulse ox, it'll be 100%, right? Because the pulse ox can't tell the difference between the CO and the O2. If you check their O2, this is very important. If they give you a blood gas and they tell you the PO2 is normal, does that rule out CO2 toxicity? No, it doesn't. They can still have lots of O2 dissolved in their bloodstream, right? The CO attacks the hemoglobin, which is the important part. So the simple answer is don't fall for any of the things that they put except for directly measure the CO level, and you'll always be fooled by the pulse ox. Now, for the methemoglobinemia, it's a classic question. The patient comes in looking blue like a Smurf, but they're not sick. They don't look terribly sick often, and because methemoglobinemia is often not that bad. Basically what it does is it takes a certain percentage off the top of their hemoglobin and makes it unusable because it's got that Fe3+. But the thing that's important about the test questions on that is they'll give you that they took something that causes that, like a medicine that we know causes it, like dapsone is one, for example, and then they'll give you this patient that looks okay, that's blue, except they're blue, and then what will the pulse ox say? It will say mid-80s, 85. That's the classic methemoglobin question, and that's because the pulse ox gets totally confused by this. It can't interpret it, and the way that it ends up manifesting is a mid-80s measurement. So that's a classic question. Okay, we're done with the physiology stuff, and now we're going to get on to the disease processes. There's no one in this room that hasn't seen tons of asthma patients, I'm sure. It's something that we're very familiar with. And so what we're going to try to do is just sort of, we're going to go through it fairly quickly, but we'll try to pick off those things that tend to come up that are a little bit obscure. When it comes to epidemiology, this is very, very important. It's a major public health issue. Asthma is one of the few things that we're not really making that much progress on, and that progress has been very slow. Okay, as opposed to other diseases. And it's very confusing as to why that might be, but some of it seems to have to do with urban environments, some of it has to do with poverty, and the demographic that's most severely affected in the US is younger African American women. So that's important from a public health point of view. We know that patients that are constantly using, what does it mean when a patient's constantly using their puffers and their inhalers? It means they're not controlled. Okay, because they should be on preventative medications. And those are things they all sort of seem to go together. Now, because asthma is so important, they might ask you some basic science stuff about it. It's quite possible. And it's really important to remember the mantra that asthma is a chronic inflammatory disease. Chronic and inflammatory. And I think that there's a little bit of misunderstanding about that. This basically shows you the progression of changes in asthma. When, 50 years ago, they just thought it was just bronchial constriction, right? And then we realized, oh no, it's inflammation, so you don't just need beta agonists, you need steroids. But subsequent to that, we've realized that it's even more than that inflammation. Asthma results in a remodeling, a hypertrophy, a thickening of the airways that it becomes a chronic issue. The most severe asthmatics end up getting lung damage. And lung remodeling. And so I want you to remember that there's that remodeling and hypertrophy that goes along with asthma. This is just another way of looking at it from a cross-section to show you the several progressive steps that happen. How many people here have had a patient with asthma die on them? Let's put your hands up. Okay, so this is pretty awful. And this is what I'm talking about. It's still happening. And when it happens, it often happens in young, otherwise healthy people, and it's a terrible tragedy. And I think the most important message for us, because several of us have had this experience, I've had it twice, I've had two die on me, it's not your fault. It's not your fault. I'm sure you gave them oxygen, I'm sure you gave them albuterol, I'm sure you gave them steroids, I'm sure you gave them magnesium, I'm sure that you did everything that you possibly could. You intubated them if necessary. But nothing in the world that you can do can ventilate through this cast. This is what you find on autopsy of the patients that you lost. You find basically a thick, solid cast of inspissated mucus. You can't let it get to that stage. That's why you need to do pulmonary toilet before it gets all solid like that. But what could you do in that case? ECMO, right? You can't ventilate past that. So that is sort of the final common pathway for death in a lot of patients. I think we all remember those common precipitants of asthma: cold, exercise, URIs, number one, right? They're not going to ask stuff like that. It's too easy. The things to focus on are the things that sometimes people forget. Beta blocker drops that people take for glaucoma can precipitate an asthma or a COPD exacerbation. Well documented. That's important to know about. And another thing is, be hyper aware of this constellation of allergy, atopic allergic dermatitis, okay, nasal polyps. If you hear all those things together in asthma, avoid aspirin and NSAIDs. That's something they want you to know. It's called Samter's triad. So nasal polyps, one of the first things that comes to mind is aspirin. In terms of the pathophys and the clinical features, of asthma, most things have to do with an inability to exhale, okay? But that's the part that we all remember. You can't exhale. There's other things that are going on here too. And one thing that I use as a mantra that I think will help you for the test and for real life is the following, which is that a severe asthma exacerbation is actually a shock state. Have you guys ever heard that before? It's a shock state. Because what happens with those patients is that they can't breathe out, and pressures in the chest, just to keep it simple, are getting higher and higher and higher, and you basically get to the point where you're obstructing your venous return. That's obstructive shock. Not to mention the fact that if you blow a pneumo, right, or you blow a couple pneumos, that's going to add to the obstructive shock potentially, because a tension situation. And it's also hypovolemic shock, incidentally, because people that can't breathe all day, that are panicking to breathe, aren't drinking, and they're losing lots and lots of fluid. So severe asthma is a shock state, and it consists of both hypovolemic shock and obstructive shock. And so that's really, really important as a part of the pathophysiology. Now, in terms of diagnostic things, these things are common, and so they're commonly asked about. I'm going to give you basically a one thumbs up, thumbs down on these things just as a memory aid. Bedside spirometry, I love it. And as a former family doc, general practitioner, I used to really rely on these things. You know, your patients would take their peak flow, their bedside spirometry every morning, and they'd be able to call you and say, hey, listen, you know, I'm down to 350, and should I start my prednisone? I mean, it was a really great thing. Unfortunately, studies in the emergency department have not shown that it really predicts outcomes. There's a lot of reasons, I'm sure, for that. You know, patients have trouble using it. They might not have accustomed to it. They're so sick that their effort is really the issue. And, you know, there's all kinds of reasons why it might not be reliable. I'm not saying not to use it, but if they ask about it predicting things, they ask about its utility as a branch point, it's going to be not right. Okay, it's going to come down to your clinical judgment, not the peak flow number. Now, this amazingly is the same when it comes to pulse ox. You might think, oh, for sure, pulse ox, that's the right answer. It's actually not. And the reason for that is because what happens as patients are getting better from asthma? Remember, asthma patients, okay, have their hypoxia from what mechanism? VQ mismatch. VQ mismatch. And so when you're inhaling that albuterol and you're opening up different areas of the lungs and stuff, there's often transient readjustments of ventilation and perfusion that result in transient hypoxia. You've all seen it. The nurse comes to you and says, oh my God, Mr. Smith is getting worse. I think we're going to need to do something. You walk over. The SAT's down to 89, right? You walk over. How you doing, Mr. Smith? He says, oh God, I feel better. I'm ready to go. Okay? And so pulse ox has not been shown to predict things for admission. Of course you use it. Of course it's important. But if they're specifically asking about its utility as a branch point, again, in asthma management, it's clinical judgment, not spirometry, not oximetry. And you won't be surprised to hear that the same goes for arterial blood gases. If you do arterial blood gases on a lot of asthmatic patients, you might be a sadist. This is something that we haven't done for many, many years. It's interesting, the discrepancy, how the internists continue to do this test universally, and how we've really, almost eliminated it from our practice. It's really painful. There's side effects from it, and it's not the way to decide. Now, if they give you gases, we'll talk about that in a second. If they give you gases to interpret, you got to be able to interpret them. But if they ask you if gases are the way to determine should an asthmatic be admitted, should an asthmatic be intubated, it's absolutely wrong. It's clinical judgment. And lastly, the chest x-ray, again, consistent with this naysayer ideology, the answer is no. They say this patient has asthma, it seems straightforward, there's nothing funny about it. They don't get a chest x-ray. That's considered a wasteful resource utilization, unless there's something funny going on. You think they got pneumonia. So that's it. Those are the common tests. So you can manage these patients pretty simply. Now, in asthma, you've all heard this concept of how things get really loud before they get quiet. Patients get more and more ramped up. The breathing gets more and more pronounced. They're tripoding. Their wheezing gets louder and louder. And then what happens? Things slow down. The wheezing starts going away because they're not moving hardly any air. Our sphincter starts tightening up because we're like, uh-oh, next thing is bradycardia, and then we're, get ready for an airway management. But that's really what it does. And so don't forget that the worst asthmatics kind of fall silent towards the end. The breathing rate might come down, and those things are really, really indications to get that airway managed, to get them intubated. Now, this just shows that same thing. It shows that as the asthma is getting worse, there's that increase effort, and in fact, the pH actually goes up initially. Because they're breathing off so much CO2. But then, as the CO2 normalizes and then goes up, they're getting into respiratory failure. So the way that this will happen on the test is they'll give you a patient that's got asthma, and they're breathing real fast. Okay, and they'll give you the gases, and they'll tell you the patient's breathing like the dickens. They're breathing at 40, okay, but their PCO2 is normal. It's 40. And you're thinking, well, if I was breathing like that, I'd breathe my PCO2 down to 15 or 20, right? If they're breathing that hard and yet their CO2 is normal or creeping higher, that is the, I guess you would say, the internist way of deciding that they're in respiratory failure, and they might want you to know that they're in respiratory failure. And so that might be a separate question. But again, if they say, do you intubate this patient, what do you use to decide? It's always going to be clinical appearance, vitals, basic clinical stuff. Okay, I hope that's straightforward enough. Now, this is a very easy slide. If you work at a place where you have one of those T systems or automatic populating things that gives you risk factors and history things on asthma, these are all the things that are there. You know, have they been intubated before? All those kind of things. And I don't think there's anything that unexpected on here. Patients that, you know, aren't treated, that are poor perceivers, that are in the ICU all the time. Obviously, you're more worried about those patients. Okay, let's talk about the therapy. And you need to know the mechanism, and you need to know a little bit about the evidence, because the evidence was robust and it's part of our general knowledge base at this point. It's been years and years studying this. So for the beta agonist, remember that that is the gold standard for asthma, and everything else is compared to beta agonist. Okay, that is the one drug that is indicated. And they sometimes ask about the beta-2 specific effects, so that's beta-2 is more specific for bronchodilation, pardon me, and then beta-2 or beta-1 is more the heart rate. So you want to get beta-2 specific so you don't stimulate beta-1 and give them as much tachycardia. Of course, there's overlap, we all know. These things in evidence are all well established, and so if they ask any of these, or they might ask it as one question, they ask these things together, who knows, but basically inhaled is better than oral. When my brother was a kid, he used to take that oral syrup, just ramped him up a bit. I don't think it helped his asthma. And so it's inhaled is superior. If they ask you about continuous versus intermittent nebulization, no difference. MDIs, if they ask you about that, completely no evidence to show that MDIs are any less effective than the masks. Mind you, in the emergency department, when they're really sick, they might be too sick to hold the thing, you know? And I don't give patients inhalers in the ER when they're in distress because I'm like, Doc, I'm dying here. I just spent all morning doing this, and now you're giving me the same damn MDI? Give me the mask. I'm okay with that. But the evidence shows that, you know, one is not superior to the other. And then the last thing is, you guys remember that craze about the leave albuterol? You know, and it was like, it's funny, the County of Los Angeles actually, I think, switched their formulary so that if you wrote albuterol, they'd substituted that. We now have enough evidence to know that that's not, it's not really superior. And so just plain old albuterol, or the Canadians pronounce it differently, is fine. Salbutamol, right? Salbutamol? Yeah. Now, in terms of how steroids act, remember that they take longer to act. There's a delayed action. It's immunoregulatory. A couple of things that, again, can come up is that oral is just as good as IV if they ask. And if they ask about inhaled steroids are okay to prevent relapse, and we prescribe them. They're very popular in Canada to prevent relapse, but that can't substitute for using PO or IV or IM systemic steroids. You can't just get away with just using the inhaled, okay, for exacerbations. Now, when it comes to most asthma exacerbations, just use albuterol, okay? And then when you get to the severe segment, when you get to that subsegment that we're starting to get worried, we're going to be hospitalizing them, we're starting worried about respiratory failure, then those patients you have to throw in the kitchen sink. None of these things are anywhere near, none of these things are as effective as albuterol. None of them. Some of them are marginally effective. Like Atrovent and magnesium are probably marginally effective. But you always use them when you think that that patient is really bad because their risks are outweighed by their benefits, basically, any potential benefits. So in terms of Atrovent, it's a bronchial smooth muscle relaxer. Magnesium is the same thing. And ketamine is definitely a right answer. You can use ketamine. Only thing to keep in mind is that when you use ketamine for asthma pre-intubation, it increases these secretions, and so sometimes that can have an untoward effect because they've got so many secretions coming out. Just be aware of that if you're using ketamine before intubation. I use it both before and after intubation now. Now, in terms of, this is a very important slide because these are things that they might put up as foils that are wrong. We don't recommend theophylline for treating asthma anymore. That funny picture that I showed there it's a long story that I won't bore you with, but basically it's showing when I was in Africa, they were the ones who taught me how well theophylline can work. I mean, they used it there because it's way cheaper than albuterol, but it's not as good as albuterol by any stretch, and it's got toxic problems. So we don't use theophylline, it's the wrong answer. If they ask about Heliox, it's the wrong answer as well. It did show some promise initially, but we've got enough evidence to show that it doesn't work for asthma or COPD. The reason why probably is Heliox makes air thinner and lighter and easier to move. And that's really, really important in the big airways, like in the trachea. So if you've got a kid with a hot dog stuck in their trachea, nothing is more of a godsend than Heliox, because immediately, I don't know if you've ever seen that, but that can immediately relieve their distress and help air get past that obstructed trachea or bronchus. But with asthma and COPD, we're talking about a football field square surface area of airways, of medium-sized airways, and the Heliox really doesn't, the physics doesn't work there, basically, the Poussil's law or whatever it was. Now, long-acting beta-2 agonists, mast cell stabilizers, also wrong. Long-acting beta-2 agonists, like salmeterol, also wrong. Leukotriene modifying agents, also wrong. So you've got this whole host of things here that are appropriate for outpatient therapy that are not indicated, in fact contraindicated in the ER, that are easy foils for these questions. Now remember, you don't want to intubate asthmatic patients, obviously. You always try to avoid that. That's, it's not great, and they're more at risk for dying, as you know. Once they're intubated, it's when things get really dangerous. And so you have to be careful. You have to be careful with barotrauma. Now, I think most of us are aware. You're watching for pneumos. You're watching for pneumothorax. You're watching for pneumomediastinum, right? That's the kind of things you're concerned about. They get worse. You take an X-ray. You do an ultrasound. You make sure there's no pneumo. That's really important. But probably the bigger issue is the microscopic damage that's happening when we overventilate these patients with diseased lungs. And so when we say preventing barotrauma, we're not just talking about not blowing pneumos and pneumomediastinum and pneumothoraces. We're also talking about not doing long-lasting permanent damage to the alveolar structure, the things that we were talking about at the beginning. And so we use this. I want you to take your pens out and circle permissive hypercapnia. Okay, for a lot of you, you know that term. If you don't know that term, that's the key thing to remember. When patients with sick lungs like asthma that can't exhale air, and this also, by the way, goes for ARDS, when they're really in trouble and you intubate them, you're never aiming for a SAT of 100% anymore. You're aiming for a SAT of like 88 to 92, that range. And you're never aiming to correct their pH and their PCO2 right away. Okay, so if their PCO2 with asthma is 60 or COPD is 80, that kind of thing, and you intubate them, their pH is 7.2, you don't aggressively ventilate them to get that pH normalized, because if you do, you're going to really damage their lungs. You don't need to worry about them, they're already intubated, so you don't need to worry about being in a rush to get their numbers in line, and often it takes 2 or 3 days to do that. So the way that you do permissive hypercapnia is don't overventilate them, don't aim for a SAT of 100%, decrease the respiratory rate. The number one thing to give more time for the lungs to get rid of their air is to set the rate low. So a rate of 6 is totally reasonable after an asthmatic intubation. So permissive hypercapnia, more time for exhalation phase, lower respiratory rates, and allowing the abnormal values to stay abnormal and slowly correct. This is sort of when the stuff hits the fan, the worst case scenario, the patient who arrests with asthma. It's a terrible thing, and it sounds like a lot of us have been in that situation. And remember when I told you that asthma was a shock state? This harkens back to that. So what I'm doing when the patient arrests is I'm doing everything to address the obstructive shock potentially and the hypovolemic shock. And that means disconnect the ventilator, okay? If there's trapped air in there, you can get it out by squeezing their chest. Remember, they've got exhausted, ATP depleted, weakened chest walls. You need to help them push that air out, because that can be causing obstructive shock and decreased venous return. You stick in bilateral chest tubes, bang, bang. No questions asked. Bang, bang. I mean, if they arrest, they've got asthma, bang, bang. Okay, because if there's tension pneumo is a cause of death, you're going to revive them. And then all the while, you're giving them a big old fluid bolus, because remember, they're very hypovolemic. And so if there's shock, hypotensive, they need that fluid as well, which is a common misunderstanding. Those 4 things must be done before you sign those pronouncement papers. Now, if you're in a place where you have access to anesthetic gas treatment in the operating room or ECMO, that's another option. And so, I don't want a kid to die from asthma just because they have bad lungs. I want to save them. And so it's totally appropriate to, if you can hang on to, if you can keep them going long enough to get them to ECMO, that's totally appropriate. The other thing is the anesthetic gases are very helpful. So when they take them to the operating room to do ECMO, for example, just the the gases are very, very potent bronchodilators, and those also help. So dispo to the operating room for an asthmatic is not a crazy thought. If that's one of the options that seems appropriate, it might be. Okay, so that's all for asthma. Wow, that's a lot of asthma. Now, bronchiolitis does not deserve more than one slide. So I've only given it one. And bronchiolitis is basically looks like asthma, as you all know, in little tykes. Looks just like asthma, hard to tell the difference. But it's a virus. It's caused by a virus. Most often respiratory syncytial virus, but it could be a lot of other ones. But the one on the test usually is RSV. And a couple of really good points for that. There's a really good mantra for that one too, which is bronchiolitis, nothing works. Bronchiolitis, nothing works. That's the thing you can remember it by. And so if they have really severe, it's just supportive care. If they have really severe presentation, it's considered by some people acceptable to try albuterol for a trial to see if it might work. Totally reasonable. But if it's not working, you stop. Okay, and you don't use it routinely, only in severe cases. That's interesting. Steroids don't work, unfortunately, so that's the wrong answer as well. And then there's this business of ribavirin. Ribavirin is this expensive agent that can be used to treat bronchiolitis, but get this, only in kids with congenital problems, in congenitally ill kids with congenital heart disease and lung disease. Yes, ribavirin, yes. The sickest normal kid in the world, no. Ribavirin is only indicated in kids with congenital disease, and sometimes that comes up. The last point I want to make about bronchiolitis is we do a swab, but we don't do a swab for the patient. Doesn't help the patient. In fact, the patient hates you for doing that swab, right? You do it for epidemiologic reasons so that you can cohort RSV-positive patients together and not spread it to the cancer patients across the hall. Okay, and that's basically what it's done for, epidemiologic purposes. Okay, now we're going to talk about COPD, and there's a lot of similarities between COPD and asthma. I'm going to contrast the differences and show you some cases that are often coming up on the tests. So, COPD is a chronic inflammatory disease. Now, I just said the same damn thing about asthma, didn't I? What is the difference between them? Well, the difference is the type of inflammation. And the inflammation in asthma that I told you about was a hypertrophying inflammation that caused a thickening, an excessive production of cells in the airway, okay? And interestingly, the chronic inflammation in COPD is just the opposite. It's a destructive protease, oxidase, basically obliterates your lungs, okay, and makes the big pockets big. So it's the type of inflammation. And the type of inflammation in asthma is associated with the eosinophils, and it's associated with Kirschner's spirals, and their sputum is yellow. And the type of inflammation in COPD is different. Their sputum is not usually, it's usually green or white, and it's mostly neutrophils in their sputum. It's interesting. They're different things and different interleukins. So that's sort of the background. Of course, the natural history, if you can think about this, is totally different than asthma because this destructive process, as you basically obliterate the parenchyma of your lungs, you just get less and less pathways for the blood to flow back to the heart. Think about it. Your lungs are being obliterated, and you end up with just a small number of pulmonary vessels that are carrying all the blood back to the heart. So you get this progressive pulmonary hypertension. The pressure in your vasculature in their lungs goes up and up and up and up, and that's how they die, because the right ventricle fails, and that's the so-called cor pulmonale. That's totally different than asthma, and that's what we're trying to avoid in this disease. You've met these folks. You know these guys? Which one of them are you going to give life insurance to? Neither? They're trying, the experts in COPD are trying to get us away from this concept of blue bloaters and pink puffers, and I'm resisting. And we've still included it, I think, in the last Rosen chapter, because I used to do this one, because it's of tremendous practical importance. Even though they're both COPD, even though there's no such thing as a pure blue bloater, pure pink puffer, the patients that are blue bloaters, they're more concerned to me, because they are the ones that basically don't have the hypoxic drive to breathe. And they're the ones that we stick over in the corner with their cellulitis, right? The nurse asks us for a Benadryl order for bedtime or something like that, and then they're dead because they stop breathing. It really is true that these blue bloaters, these people that are, walking along, they don't seem to have a big deal with it, and they're blue. It's actually what happens to them when you put all that oxygen on is they stop breathing. And so that really does happen. They're really sensitive to that. The pink puffers, the people that have the high SATs they tend to be a little bit anxious and nervous, they're thin, they're gaunt, they're not nearly as worrisome to me because they don't tend to stop breathing. They tend to hold their PO2. So when it comes down to COPD exacerbations, that's the classic definition, is dyspnea, sputum, purulence. That's all something you deal with every day. I think the main thing in both real life and on the test is to make sure that this isn't something else. Okay, so take a look at that mimics column over there. Basically, the sudden onset is the thing that most should alert you to the fact that they're dealing with something like like pneumothorax, PE, or lobar collapse. I'm going to show you some pictures of this to make it straightforward. But that's your key job when there's a COPD exacerbation. He's worse, he says he's worse, he's got sputum, is to make sure that one of these other things isn't going on. So we're going to go through that. So this is the first thing I want to show you. If a patient's really sick, they're on their back in the ER, right? Generally speaking, they're on their back. They're in the resus bay. And if we do an x-ray on a supine patient, we miss pneumothoraces, right? Everyone remembers that we miss a lot of pneumothoraces. And there's some surrogate signs of pneumothorax that you need to know. This is the deep sulcus sign. So this patient actually, you don't see the obvious pleural line like the classic textbook pneumothorax, but that's because they're lying flat on their back, and if you can imagine, all the air is accumulating. God, I don't want to embarrass myself too much here. All that air is accumulating here, anteriorly. And so when you see that deep sulcus, you're seeing this big pocket of air right in front of that diaphragm. So that's a deep sulcus sign, and that's very, very important, because if you have a COPD patient with a deep sulcus sign and they're sick, they need a chest tube, right? Okay. Now, that gives you an idea when you look at that CT scan of just how easy it is to lose half of your lung volume and you would still have no pleural line, right? If you look at that, can you envision that the chest x-ray might actually look almost normal, or it might show a deep sulcus, but it's certainly not going to have a pleural line. Okay, so you can miss more than half of pneumothoraces on just a supine film. Now, along those same lines, remember that patients with asthma and COPD get disease of their lungs and fibrosis and blebs and bullae. And one of the most frustrating things that can happen to us is when we mistake a pneumothorax for a bleb or a bleb for a pneumothorax. It's something that I share openly about how I've actually made this mistake more than once. And it's a pretty stressful situation. Basically, you look at that initial film there, and you're like, oh, I don't know, maybe that patient's having trouble breathing because they have a pneumothorax, and all that thing that you're looking at is just a bleb. And then you stick the chest tube into that bleb, and then what do you think you do? You cause a real pneumothorax. And so now, it's like you wanted it to be a pneumothorax bad enough, so you made it, that lung is pretty collapsed there, and it might, what would you do in that case, by the way, if you made that mistake? And the lung was collapsed like that. You'd stick in another chest tube. Yeah, and sometimes it might be a real problem. You might not be able to get that lung back up, and they might need surgery if their lung is really diseased and non-compliant. So, what's the bottom line? Don't stick a chest tube into a bleb, and unless it looks like a really classic pneumothorax to you, or you're pretty sure it's a pneumothorax, if you're not sure, double check. Okay, you can do a CT. Ultrasound might also help in that respect. Here's an obvious bleb. I don't think anyone would miss that. You're not going to stick a chest tube into that. This is a CT of a patient where we weren't sure, so it clarifies it. And you can see right away that the CT will not do you wrong on this, right? Because the CT is able to identify that there's no pneumothorax there. There's blebs, and the septations go straight out to the chest wall. Another critically important COPD-related issue is lobar collapse, or lobar atelectasis. This patient comes in, and they're sick as hell, and they're satting 70%. It's COPD. You intubate them. You do this chest x-ray. Most of us are accustomed to looking at white schmutz on an x-ray and saying it's pneumonia. Please add the ceftriaxone and the azithromycin, right? But wait a second, not all white schmutz on an x-ray is pneumonia. And in fact, if you look at this one, you'll see that it's basically the right middle lobe collapsed. And the way that you know that is not just the shape, but look at the diaphragm has been pulled up on the right side. Pneumonia is pus in lungs. It shouldn't cause volume change. It shouldn't shift the mediastinum. It shouldn't pull the diaphragms up or down. It's just pus in the air spaces. When you've got a lobar collapse, it's all white, and it necessarily changes the volume and pulls things up. So what does that patient need, by the way? This patient here? Immediate bronchoscopy, exactly, to get rid of that loogie that's blocking the entry to the right middle lobe. Okay, so treatment. This is different than asthma. And asthma is all about the beta agonist being the sort of the superior thing and everything else being the kitchen sink. In COPD, it's a bit different. In COPD, both beta agonist and Atrovent or anticholinergics are both indicated as first-line drugs. That's a little different. Steroids are indicated pretty much always, and we talked about that. Antibiotics, anyone who's coming into the hospital I treat with antibiotics, but strictly speaking, the criteria is they have to have increased sputum that's colored and be short of breath. You don't need to use fancy antibiotics for this. There's a lot of evidence that simple antibiotics are good enough. You have to, obviously you have to play well with others and stuff, but simple antibiotics like doxycycline might be fine. Now, non-invasive ventilation is, now it's like, it's nothing for us, right? I mean, we do it all the time, it's no big deal. It was a huge advance in this disease because it's very effective in COPD. It can prevent intubation in COPD in possibly 1 in 4 cases sometimes. The thing about non-invasive ventilation is that if you're going to use it, it must be used immediately. Be clear on that. It's not appropriate to take a patient who's struggling, giving them all the treatments, and then 2 hours later, oh, he's not turning the corner, put the NIV on it. It's been shown it doesn't work in that situation. If you're going to use it, you need to use it as soon as the patient arrives. This is severe, we're using it. And then there's lots to know about it in terms of coaching them and settings. We won't go into that, but know that this is a major, major breakthrough in COPD. Probably more important than it was in CHF. Because in CHF, we have a good treatment, nitro. In COPD, there was no other really good treatment. In terms of what actually saves lives or lengthens lives, the only evidence that we have is that stopping smoking reduces, and that's really important, right? You guys, I wouldn't be cynical about that, right? You're in the ER, teachable moment, stop smoking, big deal. Really, it's more effective than most other things, us saying that, despite our skepticism. And this second thing, home oxygen, I want to tell you, has also been shown to prolong lives. I want to talk about that for a second, okay? When you're trying to get someone home oxygen, how uptight they are about it, how you have to have the gases and it's all documented and stuff like that? Why is that? Because the reason that we're using oxygen to treat patients with COPD is a little bit different than you might think. Sure, it makes them feel better. I mean, that goes without saying. But the real threshold for treatment, the real reason that we're treating it, is that, remember we were talking about cor pulmonale and that destructive process in the lungs and the pulmonary hypertension and all that stuff? It turns out that the main driver of that terrible process towards cor pulmonale is hypoxia. And so the main reason we're giving the oxygen to patients is to prevent their PO2 from dropping below 60 or so, because when it drops below that, the progress of the disease explodes. Isn't that interesting? So we basically give oxygen to prevent hypoxia, to prevent pulmonary hypertension, to prevent death from cor pulmonale. The vaccine, very important. I don't have evidence that it's saving lives. Oh, I'm sure it is, but I don't have the evidence for that yet. Okay, let's take a deep breath. We're going to go on to a new little section, ARDS. Now, I'm going to make you feel good about this too, because it's not nearly as complicated for us as it is for other people. Whether they're talking about ALI or ARDS, they're all, for our purposes, don't worry about that distinction. This concept of ARDS, like I told you in the morning session, is basically the lungs' response to any systemic badness, right? Just like ATN is a common finding in any sick ICU patient, ARDS, as you know, is a common finding in any sick ICU patient. It's the end stage of so many different processes, right? The questions on this will be dead simple. They were trying to make sure that you know the difference between ARDS and CHF, between non-cardiogenic pulmonary edema and CHF, which is cardiogenic pulmonary edema. That's the thing to focus on. So, if they give you this information that the patient's got low oxygen, their ventricle's doing fine. This is not a CHF problem, and it's bilateral diffuse infiltrates. This is your monster here, okay? That's what you're dealing with. And as we mentioned, the causes are protean. I mean, sepsis and trauma are by far the common causes in the US, but all these other things end up with an end stage of ARDS and ATN often. And these questions will focus on, as I say, knowing the distinction between those two entities. Specifically, they'll try to get you to bite on therapies for CHF for this, and it's always wrong. So they give you furosemide, wrong, doesn't work. They give you nitro, wrong, doesn't work. They give you an ACE inhibitor, wrong, doesn't work. Anything that you use to treat CHF, unfortunately, has not been shown to work in ARDS. The only thing that really has shown to lower mortality is that ventilation strategy that I was talking to you about earlier, the permissive hypercapnia, not overdoing it, not pushing the SAT to 100, not having those pressures so high. That's the thing that's been shown to help them. That's from that AIDSnet trial that we have. Or not AIDSnet, the ARDSnet. Okay, now, pneumonia, okay, is our next topic. We're going to deal with that. I think that'll be our last one for this session. I have a way of teaching about pneumonia. You heard me refer to it, that as ER doctors, and I think this is made worse by all these silly mandates that we have to follow, time to antibiotics and stuff like that, but we see a patient with a lung, with a breathing problem of some sort. We see some white schmutz, and we're like, it's a reflex, right? It's Levaquin or Septra. You know, it's like, there's 40 patients waiting to see me. You've got breathing problems. You've got a white schmutz on your x-ray. That's good enough. You got pneumonia, okay? These are all the things that when cases come referred for problem cases and they come referred, these are all the things that show up when pneumonia was the provisional diagnosis. And so we have to kind of keep these things in mind as things that could come up on the test. They're not talking about pneumonia. Think through this list, okay? Sometimes it's just an obvious thing where a patient comes in and they set it up like it's asthma, but they tell you that the patient was mixing their cleaning fluids together, and you see that it's really a pneumonitis. It's really a potential ARDS situation. Sometimes I'll show you a patient who's a IV drug user that seems to have pneumonia, but don't forget, if they've got IV drug use, they've got circulating bacteremia, assume that that's endocarditis, and it's an infiltrate from a septic embolus before, which is more serious, before you default to pneumonia. And so they need admission, echo, right? So these are really important things. The one thing that people often haven't heard about that shows up on tests a lot because it's life-threatening and there's something we can do about it is DAH, diffuse alveolar hemorrhage. Can you circle that for me? Circle DAH. This is a really interesting thing. Here's the scenario. A young woman with lupus or a patient with a bone marrow transplant, usually the patients with significant illnesses, immunologic illnesses or bone marrow transplants, comes in with what looks like a terrible pneumonia. But the clues that it's not the pneumonia, and the clues that it's this immunologic thing, this diffuse alveolar hemorrhage, the clue is they might tell you there's a little bit of streak hemoptysis. They might tell you that the patient's got a low hemoglobin because they tend to have low hemoglobins from blood loss in this condition. And if they have enough of those things there that you're thinking this is a real emergency. If you catch these patients at the time when they're still talking to you and they're sick, and you give them these really high-dose steroids, like grams of steroids and cyclophosphamide and all this stuff, you save their life. You save their life. And it's like the only thing I would call a rheumatologist for at 3 in the morning is if I think this is going on, to be honest with you. And if you miss it, if you're just like, and I did this once, and you're like, it's pneumonia, go to the ICU, go to the ward or the ICU. By 24, 48 hours after that, as the disease progresses and they proceed to massive hemoptysis, usually they succumb to it. So that's why I took the time to explain it, because it can affect young people, and it can, as ER doctors, when we recognize it, we save their lives, because the fix rates are pretty good with the treatment. We talked about some mimics, and these are some pictures of some mimics. So I don't think many people would take a look at the one on the left and think it was just straight pneumonia, community-acquired pneumonia. That one I wouldn't spend too much time on. But look at the Hamptons hump one. I mean, if you're getting a story that sounds like maybe this is not pneumonia, maybe they're talking about pulmonary embolus, especially they say, the patient's got a fever and they're having trouble breathing and they have pleuritic pain. You're like, it's pneumonia. But remember, a couple of days after the initial PE, that's when you get the infiltrate. In fact, you get pneumonia. For all intents and purposes, you get kind of a pneumonia on top of the PE often. You get atelectasis, you can get a fever. And so if it's been it's been a couple of days and it sounds like it might have been a PE setup, and you look and you see that instead of a straightforward infiltrate, that it's a wedge-shaped thing, like this is Hampton's hump, they're talking about PE. And that's that. Now, this is a money slide. This is one that I specially prepared to get as many questions right for you as possible. And it's funny because I don't know about you, but when I admit a patient with pneumonia, I don't put acute Klebsiella pneumonia, right? Billy used to do that. He used to tell me, yeah, it's good to be specific. I said, but I don't know what it is, And that's the point. You can't necessarily tell what it is. And there's enough evidence showing that we can't tell what it is. Even that business about atypical and typical, right? They overlap. It's not always like that. But for the exams and in the textbooks, there's so much on this, you just can't avoid it. And so these classic relationships, the patient who wakes up with the shaking rigor and then has the rusty sputum in the wintertime. Okay, they're talking about strep pneumo. And so these are classic kind of biz-buzz things that you just have to know. Whether they're 100% reliable or not, that's not the point. So I want you to know those things. Remember those. Remember the Pseudomonas for the cystic fibrosis and hospital-acquired. Let's take a look at a few of these. So there's a left lower lobe pneumonia there. That's fairly straightforward. If they ask you what causes a pneumonia, your answer is always pneumococcus. That's by far the commonest cause in kids and adults. And there's a right upper lobe pneumonia that's Klebsiella. So the classic Klebsiella picture was the bulging fissure, remember that, and the right upper lobe infiltrate. And what else would you know about that patient? They might be an alcoholic or immunocompromised, and they usually have pretty gross sputum. They're usually pretty sick. It turns out that the commonest cause of a pleural effusion in pneumonia is actually just strep pneumo, but that's because strep pneumo is so much more common than everything else. If they show you specifically a pneumonia with an effusion, I want you to first think about staph, TB, anaerobes, those kind of things. Legionella is listed there. I highlighted TB because that's the worst one to miss, right? I mean, that's can be disastrous when you spread TB through your hospital. This yellow box is very, very important because, again, it's getting down the wrong track is where we get into the wrong, where we get into trouble in emergency medicine is getting down the wrong path, not necessarily the finesse. And so the patient comes in with an isolated, left-sided effusion, okay? That's all you have. It's an isolated left-sided effusion. Please think first about really bad things that do that. And Boerhaave does that. Boerhaave causes an isolated left effusion because it rips through that side. And aortic dissection, type B dissections, can rip through and cause hemothorax on the left side. So if you see an isolated left-sided effusion, and that question, they're talking about dissection, they're talking about Boerhaave's, you'll know, but just remember those prompts. And if it's just on the right side, it could be CHF, and then it could be something to do with the organs under it, like a liver abscess or liver process, that kind of thing. Now, if you see a cavity, think TB. There's an air fluid level in that. It's probably not. It's probably an anaerobe. Staph does it. Pseudomonas does it. Those are the common ones. Now, this slide is another money slide. I want to spend a second on this one. When we talk about atypical pneumonia, the term is outdated, right? That there's this overlap between, the atypical was the walking pneumonia, that sort of colloquial way we used to use the term. Oh, it's walking pneumonia, they're not that sick, they get macrolides. And then the typical pneumonia is a lobar infiltrate, and they're sicker, and they get, they might need more. That's sort of the what we were all sort of taught. Really, what atypical really means is it doesn't show up on a gram stain. So these really are truly atypical microbiologically, but that's just a gram stain thing, okay? And that might come up because they might tell you the patient's got pneumonia and nothing shows up on the gram stain. I'll show you that in a second. But this gets into the concept, this atypicals, of the pneumonia plus syndrome, because they show you pneumonia, and it's definitely pneumonia, but there's enough stuff there to give you an additional diagnosis on top of that. So you give them what they're looking for. So if they give you a young person who's got pneumonia, but they have Guillain-Barré that Peter just talked about, or they have bullous meningitis, they have erythema multiforme, the target lesions, that's another classic one. For sure, they're getting at mycoplasma. In chlamydia, they're talking about the little kid who acquired it from the birth canal, who's got the staccato cough. Legionella is a different one, because Mycoplasma and chlamydia usually are kind of diffuse interstitial pneumonias. They're usually not that life-threatening. Legionella can be like that, but when they ask about Legionella on our tests, they're looking for the bad Legionella, which actually presents more like a really severe Pseudomonas or pneumococcus. They can present with big, large infiltrates. They're sick as heck, as you know. And the way that you know that it's Legionella on the test is they'll have GI symptoms. They'll have vomiting, diarrhea, okay? And then there's a few other things listed there, but the GI symptoms are the main thing. Those are really sick people that need to be ICU admits usually. Now, if you see interstitial infiltrates, we talked a little bit about PCP pneumonia, that could be it. Mycoplasma can do that, viral things can do that. But doesn't this kind of just remind you of what I was saying this morning, which is read the question? Because when you look at these chest x-rays, I mean, you're going to be looking on some computer in a test center that doesn't have nearly the resolution of your PACS system where you work. And honestly, when you look at these chest x-rays, just look, is the heart big or small? Is there schmutz on both sides, one side? Honestly, just infiltrates. Just basic things like that. Is there obvious hilar adenopathy or not? If you find yourself in the test center going up to the screen and looking for curly B lines, you go to the next question, you know? You should be able to get it right by what I said. Heart big, small, schmutz on one side, just that, and the question should do it for you. Because I don't know what the hell this is. It could be aridity, yes, it could be anything, you know? So, Mycoplasma classically has the perihilar infiltrate. Again, it could be PCP, it could be viral pneumonia. Legionella, I had mentioned, is different than the other atypicals in that it's on the test, it's usually the really serious life-threatening thing with big lobar infiltrates. And now I talk about the really atypical pneumonias. This is actually very fun. Hardly any of us ever see this stuff, so that's why you're going to see it on the test, right? And so here, it's just a matter of memorizing these key things, and you just give them what they want, right? So if they give you a goat or a sheep, you give them Q fever. That's what they want. If they give you a bird handler, give them psittacosis. That's what they're looking for. And these are the classic associations that come up again. You know, this is no small thing, these things, by the way. They're rare, but these are very dangerous, life-threatening diseases. So that's why it's not bogus for them to ask us about it. So you got someone who comes in really sick with pneumonia. By now, most of us are used to saying, hey, have you traveled? You know, are you immunocompromised? Do you have any hobbies? Do you go spelunking in caves? These things become really relevant in pneumonia now. And on the test, they'll give you one of these pneumonia plus things to get the right diagnosis, okay? Fungal pneumonia is a delicious one. I love it. It's a great question. It's a patient who has a subacute presentation. It's maybe 2 or 3 weeks. They come in with the coughing. Their x-ray looks like diffuse infiltrates. But the key things to getting it right are, where are they from? Because remember, Ohio Valley, the San Joaquin Valley, these special American places, the Southeast, the Blasto, the Histo in Ohio, River Valley, the higher in Ohio, and then in California we have all the coccidioidomycosis. So those are where they're from is a big clue. The fact that they have erythema nodosum often, they'll show you this patient, they have big, painful red erythema nodosum, and the fact that they have hilar adenopathy. That cinches this diagnosis. I'll say it one more time. Erythema nodosum, delayed presentation, bilateral infiltrates, big hilar adenopathy, and coming from one of the typical places or hanging out in caves. Now, when it comes to the gram stain, again, we're not that geeky in our worlds, but they are at ABM General, and they'll go over to the microscope slide. And I've made this so that I color-coded it. Those first 4 gram positive are purple, or blue, and then the red ones are the gram negatives down there. And notice the last 3 entries, chlamydia, Legionella, and Mycoplasma, the true atypicals, do not show up on the typical gram stain. Okay, so they might show you that. Don't get it wrong. What is it? Gram positive, they're kind of couples. That's strep pneumo, definitely know that one. Definitely know this one too, because it's so typical looking. These very symmetrical, box-like rectangular structures like that, gram-positive bacilli, that really is anthrax. Something that you should probably recognize. And there's all kinds of ways in the question you might recognize it, but that's anthrax, and we'll get to that in a bit. I think we're going to end just after this slide. I want to complain to you a bit about that Sanford guide. You guys know the Sanford guide of antibiotics? Do they still use that? I don't hear as many people complaining as me. It was started off as a single laminated sheet when I was a house officer, and now it's a thick book that requires special microscopic, honestly, I can't it's unusable to me. It's like I look it up and it's 15 lines of microscopic text with exceptions and acronyms and footnotes and OMG, it sucks. So I see pneumonia antibiotics as the easiest thing in the world. I see it as a 3-step thing, and that's how it is on the exam, and so let's just go with that for now. There are young or healthy outpatient people, they got to get a macrolide. They get strep pneumo, and those atypicals are covered by macrolides, okay? So that's the one set. And then it's just a matter of adding as necessary. So they're older or sicker, hospitalized, then you have to add gram-negatives. Well, there's your ceftriaxone. And of course you can cover the 2 with levaquin, but don't, because we want to save the levaquin for when we really need it. So use the cephalosporin and the macrolide. Okay, and then we go to the next tier, which is they're older, they're sicker, and they have, they're in dialysis centers and they're exposed to MRSA, and they've got multiple intubations and they might have Pseudomonas. They were in the hospital last month. And then you cover Pseudomonas and MRSA as necessary, and that's it. And why they have managed to turn that into such a nightmare, I don't know. But that's all you need to know for the test. So you add the Vanco for MRSA and an anti-Pseudomonal cephalosporin or carbapenem or an aminoglycoside for the Pseudomonas. That's it. That's all you got to know. So I'm going to end there at the pneumonia treatment, and we'll do the second half after the neuro, I guess, right? Thank you guys very much. We'll see you soon.